what I want to start with is just saying that this really is emerging, and a lot of the case series I'm going to show are really early evidence that we have some changing lipids, blood pressures, things like that. This is sort of alarm bells that we should be paying attention to this as our patients get older. I have no relevant financial disclosures, but my one disclosure for this talk is I am a pulmonologist talking about cardiology and endocrine topics, and so you'll have to give me a little bit of leeway in that since this is outside of our normal specialty. Just a quick outline, I'm going to talk about our historical context, what's happening with modulators in terms of weight, what's going on with blood pressure, lipid metabolism. I'm going to briefly talk about some insulin changes, and then the emergence of metabolic syndrome, which we'll learn all about here near the end of the talk. By the end of this talk, I hope that we understand the emerging risks for cardiovascular and cerebrovascular disease in our folks with CF, and then discuss the metabolic risks and discuss emerging metabolic risks as in the endocrine department. And then, postulate some of the screening things we may do to help improve our care for our folks with CF. And then for you that have CF, you can advocate for yourself as your physicians who focus mainly on your pulmonary health tend to put these in the background. So I'm going to start with a case, and I think this is relevant to many of us who care for people with CF. So we had a younger gentleman, 31 years old. He's heterozygous for Delta F508. He has mild obstructive lung disease, pancreatic insufficient, and he already had some metabolic risk. He had CF-related diabetes, CF-related liver disease. It's 2019, so we started him on elexacaftor, tezacaftor, ivacaftor, which I'm going to call ETI from here on out. At enrollment, he actually was already in the overweight category, so his BMI was 27. His blood pressure was pretty well controlled, 125/78. Triglycerides were in the normal range. HDL is a little bit low for men. We want that above 40, actually. LDL and total cholesterol look good, and his diabetes was very well controlled at 5.3. Fast forward a year, he's now actually into the obese category. His weight has gone up by 9 kilograms. His BMI is in 31 now. His blood pressure is into the stage 2 hypertension group. His triglycerides have gone up significantly, 262 now. Above 150 is when we start to get worried. Still has low HDL. With those three, he automatically reaches criteria for metabolic syndrome. Diabetes is still well controlled, though. Again, going forward another couple of years, we're now at 5 years, his weight's gone up another 10 kilograms. So really the question is, should we start to worry about metabolic syndrome? Should we worry about cardiovascular disease in this gentleman? I think this is something that we can apply to many of our patients. Historically, when we think about cardiovascular disease and CF, we think all about the right heart. So we think about pulmonary hypertension, right heart failure, mainly driven by our chronic hypoxia, chronic inflammation that leads to lung destruction, ventilation heterogeneity. That again changes the vessels. But I think it is important to point out that the CFTR mutation is found on cardiac myocytes and in the smooth muscles, which control our blood vessels. In a lot of mouse models, they've shown that there's changes in myocyte contractility, intracellular signaling within the blood vessels, some increased fibrosis in those mouse models. We haven't really seen that translate into the adult population or into the human population. But really what we don't know is what ETI is going to do to these things as we move forward as our patients get older. And really, if you think back, historically, we've thought people with CF were relatively protected against cardiovascular disease. They were young, tend to avoid smoking. Their lipid profiles are actually favorable. They have low total cholesterol, low HDL, low LDL, isolated hypertriglyceridemia. They do have a low incidence of hypertension, really traditionally low or normal blood pressure or BMIs. And then they have CFRD, which has never really been shown to be associated with macrovascular diseases like coronary artery disease or cerebrovascular disease. And really that was supported by this case series from a couple of years ago where they took 14 patients who were older, over the age of 40, 50% had diabetes, 70% of them already had some dyslipidemia, and they did caths for them because they were undergoing lung transplant eval, and not a single one of them had coronary artery narrowing or atherosclerotic plaques. However, we're starting to see a lot of people focus on these emerging cardiovascular risks, and some of the things that we traditionally associate with cardiovascular disease are starting to emerge within the CF population. And so we're seeing our patients getting older, so that's great, but the changes that come along with that are something we have to pay attention to. BMI and body fat are going up. We're seeing changes in blood pressure in the wrong direction. Our cholesterol levels are all going up. And some things are protective too. So our oxidative stresses, systemic inflammation, things that we would worry about for cardiovascular disease are actually getting better over time. It's really no secret that modulators cause weight gain in all of our patients, and going all the way back to ivacaftor in patients who had a gating mutation with G551D. After 48 weeks, we saw a 3-kilogram weight gain for those patients. Even if you were on modulators before, and then you went to ETI, so tezacaftor, ivacaftor to ETI, even after 4 weeks, your BMI increased by 0.6, weight went up by 1.6 kilograms. And in those folks who are heterozygous for Delta F508 who got put on ETI, by 24 weeks, we see that their BMI just keeps going up, and we just don't know what happens after that. That's what we're looking at now. If we look at the CF patient registry, I know Dr. Euler put a slide up like this before, but in 2004, 14% of people were overweight, 4% were obese. And then in 2024, we're now up to 29% of our patients are now overweight, 14% are obese. We're still nowhere near the general population where we have 40% of people in the US who meet criteria for obesity. So we still have a long way to go to that, but we should start paying attention to this. And in this paper that was published by Zempateri et al. In 2022, they showed in yellow people who are overweight are going up steadily over time. People who are obese in gray is going up, and then our patients who are underweight is going down. Looking in this CF patient registry, the risk for being obese is having a more mild mutation, class 4 or class 5, if you're getting older, if you have access to modulators, which is now greater than 90% of our population, and if you're pancreatic sufficient. So that's great, right? Our patients are gaining weight. That tends to be associated with better lung function. But really, where is that weight going? Because that's really important. And so we have a couple different groups who have looked at weight distribution. For the first two are using bioelectrical impedance, and then a couple of imaging studies. So in this group out of the UK, they showed both an increase in fat-free mass index from 18.1 up to 18.9 and fat mass index. So they're gaining both muscle and fat in those groups. Men tended to gain muscle better than women. And a different way that they looked at this in the figure is looking at people who are normal weight obese. So this is women who have a body fat content of greater than 30%, men is greater than 23%. And they showed in their total group, the number went from 10% of their population before ETI up to 20%, so it doubled. Women went from 25 up to 38% of their population, and men went from 5 to 9, so almost doubling. But in kind of a different way to look at that also is that the people who met criteria for low muscle mass, so that's that low fat-free mass index, went down. So people were getting both muscle and fat in this group. Contradictory to that is this group out of Spain who looked at a small number of patients using, again, bioelectrical impedance, and they showed increasing BMI, fat mass, and visceral fat. And the more that you gained your BMI, so 1 point, 2 point, 3 points, the more your percentage of fat went up. They didn't show any difference in fat-free mass or muscle mass change. So in this group, they're saying that people are gaining all fat. It's not really a lot of muscle. So that's important to know. What if you don't trust bioelectrical impedance? Because there's a lot of error within that technique. So that same group looked at CT scans. And so they looked at body composition using a special program within a CT scan. Our patients get a lot of CT scans anyways. So they looked before and then 6 months after getting ETI. And this is at the level of T12. The computer program then calculates your total body area, fat mass, muscle concentration in different compartments. And they showed increases in total body area, total fat mass, visceral fat, intramuscular fat. And the only muscle compartment that they saw change was the very low density muscle. So again, just all fat, no extra muscle for these modulators. Different imaging techniques. So we're looking at DEXA scanning now. So all of our patients over 18 should be getting a DEXA scan. So we potentially could be doing this on everybody. And they looked at patients, just a small number, but on ETI for up to a year. Each one of these lines represents a different patient, and all of them gained weight. Most of them gained BMI. All of them gained fat-free mass or fat mass index, but none had changes in their fat-free mass. So this is their fat mass index. This is their fat-free mass. So again, supporting the idea that we're gaining mainly adipose tissue. Why do we care so much about adipose tissue? Well, in the general population, central adiposity, increased waist circumference is associated with higher levels of visceral fat. And with that, higher waist circumferences are a strong indicator for development of coronary artery disease, and then type 2 diabetes. So type 2 diabetes is mainly insulin resistance. That's not really what we associate with CF-related diabetes, but something that we should be paying attention to. This is particularly important when our waist circumferences reach 102 centimeters for men, 88 centimeters for women. And if we look at our own center at UT Southwestern, for all of our men after a year, they had an average weight or waist circumference gain of 3 centimeters. And for men or for women, it was 4 centimeters. That still stayed within the normal range though. So 86 to 89, 78 up to 82. So this is a short time. It's only a year, but certainly trending in the wrong direction from that. The fat distribution isn't something that we can ignore though in our young population, because in this recent publication where they used the NHANES data to calculate all-cause mortality and heart disease mortality in patients between the ages of 20 and 50. They were using a 15-year mortality calculator. And what they showed that patients who had higher body fat, higher waist circumferences compared to matched controls had a hazard ratio, so almost a 2 times greater risk of all-cause mortality and heart disease mortality. But if you just looked at BMI alone, there was no difference between age-matched controls. So we really should be paying more attention to this than we do for BMI, though BMI is what's reported in the CF patient registry. It's a lot what we track in clinic. We don't really track waist circumferences as well. Hopefully now that I've talked a little bit about where that weight's going in our patients, I think we can shift gears and talk about blood pressure. Really, I think this is the most pressing thing that we need to address within our cardiovascular risks since it has the most signal for it. Before we talk about the effects of highly effective modulators, though, we really need to talk about how do we diagnose hypertension? Because most of the time, our patients come to clinic, they get their blood pressure monitor there, or blood pressure checked there, and then they go about their day, whether we pay attention to it or not. But really, if we get a clinic blood pressure between 140 over 90 to 180 over 120, the next step should be offering ambulatory blood pressure monitoring. And so there's a lot of issues with getting this covered by insurance. Who do we refer for this? I know in Dallas, we have a lot of Medicaid patients who can't actually get it at our center. So that's something that we have to worry about. The technique for this is actually takes 2 measurements per hour when the patient's awake and 1 measurement per hour overnight. This is to uncover masked hypertension. I'm going to talk about that in the next slide. The alternative to this is that we use a validated device and tell patients to check their blood pressures at home, and then we average those. And to diagnose blood pressure or hypertension, it should be 135 over 85 for that average. The recommended in-clinic pathway is also probably different than what the majority of us see. And so this is recommended that we do an attended automatic office blood pressure measurement. And so that's 3 measurements. You wait 5 minutes, check another 3. And of those 6 measurements, you actually take the average, and then you're looking for that 135 over 85. So I don't know how many clinics are actually doing that or not. That's certainly something we should be advocating for. The reason that it's important to do that ambulatory blood pressure monitoring is actually the risk of mass hypertension. So this is people who have normal blood pressures in clinic, but elevated ambulatory blood pressure monitoring. And if you look at the NHANES data, so this is a very large population-based study in the US, they estimated that 25% or almost 25% of the US population had masked asleep hypertension. And this has a higher risk of people who actually have white coat hypertension. So if you have white coat hypertension where your blood pressure is elevated in clinic, but normal at home, that had a much lower risk of organ damage, such as carotid artery atherosclerosis, ventricular hypertrophy. And really even if we try to treat blood pressure and it's uncontrolled at home, so we have mass still uncontrolled, it's a independent cardiovascular risk or independent risk of cardiovascular disease from that standpoint. The risk in our population is really important because men are a much higher risk of this, and also middle-aged patients. So if you're younger, you actually have a higher risk of having mass hypertension than if you're older. So we may actually be missing a lot of our patients by just doing in-clinic monitoring. Again, we really need to know what we're looking at when we look at blood pressure. So normal now, based on the American Heart Association and the European guidelines, is less than 120 over less than 80. Elevated is 120 to 129 over less than 80. Stage 1 is 130 to 139 over 80 to 90. And anything above 140 over 90 is considered stage 2. So really those stage 2 people are the people we need to be controlling a lot better. If there's a discrepancy between the groups, so if somebody's 145 over 75, that automatically puts them into the stage 2 hypertension. If we look at starting off with the CF patient registry data, so in 2023, 8% of our population over the age of 18 had hypertension. If you had advanced lung disease, you're up to almost 14%. But this is probably underreported. Since this is, again, just what we're looking at in clinic and then putting into the CF patient registry. The first group that looked at this was the group out of Washington University in St. Louis. And what they showed that after a year of ETI, the average blood pressure increased from 120 over 75 up to 127 over 81. So now we went from normal up into the elevated category. They calculated an annualized rate of change of about 5 millimeters of mercury for systolic blood pressures and 3.5 for diastolic blood pressures. But I thought the figure for this was interesting because you see that the number of people who meet normal hypertension or normal blood pressures went down significantly. And the number of people who are stage 1 and stage 2, so those people who we should be thinking about therapy for, or at least lifestyle modifications for, went up significantly. This is really similar to what we saw at UT Southwestern as well. So from our metabolic syndrome paper, we looked at everybody who got exposed to ETI. We looked at people who were never on modulators before, and then people who were on tezacaftor, ivacaftor before. And we saw the same thing. At 1 year, far less people met criteria for normal blood pressure. We had a lot more people with class 1, class 2. And then for the people who are on tezacaftor, ivacaftor before, they did have more class 2 hypertension, but really no difference in class 1. We looked at this a slightly different way too. So if we were looking at our group of people who met metabolic syndrome at 1 year, so that was a group of 30 patients, 13 initially, went up to 30 at 1 year. We went from 8 people initially, and that jumped up to 20, which was a significant increase after 1 year. So a lot of people that we're starting to see that should be paying attention to therapy. These effects just don't go away though, because now people are on these modulators for a much longer time. So at our 3-year mark, we saw really the same results, persistent results. So a lot less people with normal blood pressure, far more people with stage 1 and stage 2 hypertension. This is also seen at the University of Michigan, who published a series with 237 patients. They defined hypertension of greater than 130/80. And their number of people who met diagnostic criteria for hypertension doubled at 3 years, went from 16 up to 29, and 10% of their patients either needed new therapy or they required intensification of their therapy. The other thing to think about is, does weight in CF affect blood pressure? So this is very similar to the general population. So this is a group out of Montreal, and they looked at patients before getting exposed to modulators, and they showed that people who were underweight and normal weight had lower systolic and diastolic blood pressures than those who were overweight. I will point out that the numbers are still within the normal range, but this is before exposure to ETI. So, so if you combine weight gain plus exposure to ETI, is that going to kind of amplify that effect of hypertension that we're seeing? I like to think of this too as a lot of those classical risks that we think of for hypertension. So that's what we see over here on the right, like increasing age. We're seeing more people with overweight and obesity. At baseline, our patients have low HDL and elevated triglycerides, so they're at risk. And then, a lot of our patients have sedentary lifestyles, just like most of the US. Who doesn't have psychosocial stressors, which is one of those risk factors that we just can't avoid. We really should be paying attention to this because hypertension in and of itself is associated with mortality. And so again, referencing that NHANES data, if you're looking at all-cause mortality, hazard ratio was 1.4, cardiovascular disease-specific mortality, development of heart disease, development of cerebrovascular disease is all increased if you have uncontrolled hypertension. If we treat it and control it, so that's the green line, it actually goes back up to normal for people who don't have hypertension. So we really should be aggressive about diagnosing folks and then starting treatment for those to get them back up to normal. It's not just mortality though. So things like strokes, cognitive impairment, vision loss, heart failure, kidney disease, which all of our patients are at risk of already. And if you really want your male patients to be interested in blood pressure, you can talk about their sexual dysfunction in the future. So again, I think blood pressure is the thing that is most pressing out of all of these things I'm going to talk about today, and really something that we need to start addressing sooner rather than later. I will say also that our modulators do have some effect on our modulation of lipids. And so at baseline, we have a couple different case series that were published. So this one was out of Emory. A third of the patients had diabetes. A quarter of them were already on insulin. And what they showed in all of their patients versus age-matched controls was lower total cholesterol, lower LDL, but no differences in HDL or triglycerides unless you were over 30. So once you get above 30, then the triglycerides exceed the general population. So as our patients are getting older, that's something that we're going to have to start thinking about treatment for that. Another group looked at this a little bit different way. So they split their patients up into patients who at baseline had hypertriglyceridemia versus the whole population versus controls to match the hypertriglyceridemia group. So this table at the left is people for total cholesterol. So for all age groups, it was lower than the general population. But even if you were a CF control, so this is talking about, even if you were a CF control, you were still greater than the US population at all ages. So even our patients who we would call controls versus our hypertriglyceridemia patients still have high triglycerides. I found this interesting is kind of the association between lipids and CF-related diabetes, because when we think about type 2 diabetes, having type 2 diabetes is generally associated with having worse lipid profiles. And this group followed patients for a long time, 8 years for those who didn't develop diabetes, 6 years for those who did develop diabetes, and they didn't see any change. So, this suggests that even if patients develop CF-related diabetes, that isn't an independent predictor that they're going to develop lipid abnormalities. Going back to that Montreal group, thinking about weight associated with lipids because we associate obesity in the general population with having abnormal lipids. And they did show this is out of Canada. And so they report in millimoles per liter, which is different than what we think about if we're US population, US physicians and patients, because we think about milligrams and deciliters. So I put normals over here on the left just as a reference for that. And they showed that total cholesterol was increased in those who are overweight and obese, still within the normal range though. Our LDL was increased, but there was no difference in triglycerides or HDL. So that didn't change. Now we can talk about the effects of modulators on our lipids though. And so in this study out of the University of Virginia, they had people on ETI for 1 to 2 years. And so we have total cholesterol up here in the top right, and their mean cholesterol levels went up by 15, stayed below 200, which is the cutoff, so still within the normal range. This is mainly driven by people who are pancreatic insufficient. It didn't matter if you're on modulators or not before. Down here in the bottom left, we see the change of LDL. And so this went up by about 10, 9.3. Some of the people in this group, though, were starting to exceed the safe range that we think about, which is 100 for LDL. So potentially something that we need to think about for treatment. Again, this was driven by patients who are mainly pancreatic insufficient. And then they also saw a significant increase in HDL by almost 4 milligrams per deciliter, so down here. But this is gender specific, and so they're all below 50. So if you looked at these all as women, that they would be too low. This is another group that kind of saw similar results over time. So this is people who are on ETI for up to a year, 1 month up to a year. They saw significant increases in total cholesterol, LDL, and HDL. They also looked at VLDL and triglycerides and didn't see any difference. VLDL is really important because it actually is the lipid that we associate with cardiovascular plaques. So the fact that that's not changing is encouraging in this group. They also looked at the changes in lipids based off of people's weight gain, and they saw no correlation with how much somebody gained. So that's also not a good predictor for what's going to happen with people's lipids. This is from the PROMISE study that I think most people are familiar with. So this is a prospective observational study in patients who got ETI. So this is notably a younger group of patients. So these are 17-year-olds, far less diabetes than some of the other groups, so only 13% of them. They were followed for up to a year and a half on ETI, and they saw significant increases in total cholesterol and HDL. Interestingly, they noted that 50% of their folks at baseline had low HDL, and just being on ETI did not improve that out of the low group. So it didn't save you from where you were at that point. And then this is our data from UT Southwestern, and we really focused on HDL and triglycerides because that's what goes into metabolic syndrome. And so our population was older, 30 years old. A third of them had diabetes, so similar to kind of the general population that you would think about. Our patients did gain weight. They gained 4 kilograms over a year. And we really saw no change in HDL. And our triglycerides went up by 21, but that was not statistically significant whenever we did our results. So what I would say kind of in summary of the lipids here is that we are seeing some worrisome trends, but people are still staying within the acceptable ranges at this point. But this is something that we need to pay attention to over time. The next thing I'm going to talk about is kind of the least convincing here. So I'll try to not spend too much time on it, but we all know that age is an independent risk factor for CF-related diabetes. And this paper is from the CF patient registry. Right now, as of 2024, a quarter of our population over the age of 10 meets criteria for CF-related diabetes, but this is with us only screening 35% in any 1 year. So we're really poor at screening adults for CF-related diabetes, and we still see a quarter of the population meeting criteria for this. Most of the complications that we see from this are all microvascular. So retinopathy, neuropathy, nephropathy, things like that. Up until this point, really, nobody has shown clear evidence that there's macrovascular complications. So no strokes, no coronary disease for this. But in this one case series where they looked at 70 people who had CF-related diabetes, they matched it with type 1 diabetics, and they showed lower rates of retinopathy, similar rates of neuropathy and nephropathy, higher rates of microalbuminemia, so some evidence of kidney damage. We all know that type 1 diabetes is associated with cardiovascular disease down the road. So who's to say that as our patients with CF-related diabetes get older, that we don't start seeing a lot of these macrovascular complications. This low rate of microvascular complications is kind of mirrored within the CF patient registry, where we still see relatively low complications. So 1.5% of people have peripheral neuropathy, 1.1% have retinopathy. So we still have time. We have time to look at this and address it. So before we get into modulators, I do kind of want to point out a couple studies that look at things like insulin secretion, insulin sensitivity within patients with CF, because when we think about CF-related diabetes, we don't traditionally associate this with insulin resistance, which is the type of diabetes that we associate with cardiovascular disease. However, in this, again, the Montreal group, they looked at patients who were overweight, underweight, normal, overweight, and they looked at people who were getting oral glucose tolerance tests, and they showed higher rates of insulin secretion, lower insulin sensitivity to achieve the same oral glucose tolerance test results. And so that does suggest that maybe there is some association between weight and sensitivity. These insulin sensitivities are still within the normal range, though, so I didn't want to overblow these results here. They also followed patients for almost 4 years, and they looked at patients who gained weight. So if you gained more than 10% weight versus staying the same or lost weight, and again, looking at that insulin sensitivity index, and they showed lower insulin sensitivities in those folks who are gaining weight over time. So this is particularly relevant in our patients who get exposed to modulators, and then they gain significant amounts of weight. This is just a graphical representation for that, where it shows patients who are obese. So the top line required a lot more insulin secretion, so significantly more insulin secretion to achieve the exact same glucose curves. So some sensitivity issues there. Again, to reference the PROMISE study. And so again, younger population, this had 79 patients, and they looked at 3 different time points. Enrollment before they got exposed to ETI, 12 to 18 months, and 2 years to 2.5 years. And they actually saw modest improvements in A1C. So this is all of the patients included. So it went from 5.8 down to 5.5. No difference in, they did see a slight increase in fasting glucoses, but no difference in 1 hour or 2 hour. And then when they looked at insulin sensitivities, they saw significantly worse insulin sensitivities at 2 years. Again, still within the normal range, but it does trend in the wrong direction. And they saw that there are some people who get better oral glucose tolerance testing whenever they start ETI. So green is in the group that's impaired glucose tolerance. Blue is the people who have CF-related diabetes at baseline. They see some people actually going up into normal, which is red. Some people going from blue up into green. So, this may not protect us completely from CF-related diabetes, but it may actually improve some of our control. This small study also supports that, where they took patients 12 years old. They were only on ETI for 4 weeks. And they said 50% of their population had improved oral glucose tolerance testing results afterwards. And then they showed lower rates of late phase insulin secretion. So that's this graph down here. So potentially suggesting some more insulin sensitivity. So kind of the opposite of what those first things showed. If we look at what happens before and after ETI, so this is a short study, patients who are only on ETI for 10.5 months, they collected things like fasting glucoses, they did a 2-hour oral glucose tolerance test, they did C-peptides, insulin secretion, and they showed no differences in fasting glucoses after a year, 2-hour oral glucose tolerance test, but they did see more insulin secretion, so that's that fasting C-peptide. They used this HOMA-2-IR score, which is actually an insulin resistance score. It's a mathematical model. And they showed significant worsening from 0.69 up to 0.96. Actually, the thing about this, though, even though it's significantly worse, it's still within the very well-controlled group, because normal is 1 to 2. And if you're better than 1, you're actually still very insulin sensitive. So it's trending worse, but not anything to worry about, I think. So now that we've talked about that, we kind of can combine everything together, which is what we looked at UT Southwestern, which is the emergence of metabolic syndrome a year after we started ETI in our patients. So, what is metabolic syndrome? So we have to define it before we can talk about it. So this was actually an old definition. It was created in 2005. And you have to have greater than 3 of the following. So abdominal obesity defined by waist circumference, elevated serum triglycerides greater than 150, low HDL, high blood pressure, which is defined as 130/85. And then the biggest kind of stickler for this definition when we apply it to people with CF is this insulin resistance, because again, we just really don't see that with CF-related diabetes. However, I will point out that if you look at really any one of the biggest critiques of metabolic syndrome is if you combine any 2 to 3 of the categories and you compare it against the whole syndrome, it really is equally as predictive. So even if we took out insulin resistance, that may not affect our risk down the line. And so the idea behind it is really driven by insulin resistance. So insulin resistance, hyperinsulinemia, hyperglycemia combined with increased adipocytes, which are these cytokines that causes vascular inflammation. You get coronary vascular disease, strokes, things like that. A lot of meta-analysis have looked at overall risk of this, and we see increased cardiovascular disease risk of 1.5 to 2.2, all-cause mortality risk of 1.27 up to 1.6. And it's not just cardiovascular disease. So people who had elevated AST and ALT, they looked at the risk for non-alcoholic fatty liver disease, so something that our patients with CF are already at risk for, and they saw an odds ratio of 2.5 times their matched controls. Same thing for CKD and microalbuminemia. So having these puts you at higher risk of these conditions, which our patients are already at risk of. At UT Southwestern, what we showed is that at baseline, we had 13 people who met metabolic syndrome criteria. That more than doubled up to 30 by 1 year. If you were never on modulators before, that seemed to drive it from 4 to 12. If you were on Teza-Iva before, you did have an increased number, but it just missed statistical significance. In our group, we had small numbers of people who were on Lumacaftor, ivacaftor, and ivacaftor alone. We did see increases in every single group, though, they're meeting this criteria. What's changing for those things? So really it was driven by hypertension and hypertriglyceridemia. So kind of changing that thing. We didn't see any change in the people who met criteria for low HDL, which mirrors what we saw in some of those endocrine studies. No difference in diabetes, no difference in truncal obesity. So with all of these things together, how do we approach our patients in terms of cardiovascular disease risks? So right now, there's really no validated 10-year cardiovascular score that we can use for our patients with CF, which is what Dr. Euler talked about earlier. But right now, the best one that we have really is this QRIS3 calculator, and this is all the variables that are included in it. So there's quite a lot, but it does include a lot of other chronic inflammatory conditions like lupus, rheumatoid arthritis, HIV, exposure to steroids. And so, in this group that looked at this calculator, a year after taking ETI, their cardiovascular risk increased from 5.2 up to 11.8. This was driven really by BMI. And I think that's really how the calculator is designed, because it does split it into groups of 10 for blood pressure. And so 120 to 130 had the same risk as if you went. So if you went from 122 up to 128, same risk. This is a different calculator people use. So this is the Life CVD score. This was developed by the European Society of Cardiology, really focusing on younger people who'd never had cardiovascular disease before. And so the variables included here: gender, systolic blood pressure, diabetes status. And this group showed, after 6 months of ETI, higher LDL, higher triglycerides, no difference in the HOMA-IR scores. And then their lifetime risk of cardiovascular disease went from 23 up to 27%. So they are seeing increases. And Dr. Euler had included this study too, and I'm going to talk about it really quickly. This group out of the UK looked at 2 different databases, so the TriNetX and then the UK CF registry, and they looked at major adverse cardiac events, which was MIs, left side heart failure, atrial fibrillation. The TriNetX had 6 million encounters. It's this multinational database. Of that, 6,200 of them had an ICD-10 score or ICD-10 code with CF, so they got included. So that's where this TriNetX group comes from. That group had a lot higher rates of hypertension, lower rates of diabetes, higher rates of CKD. And if you look at the actual number of major adverse cardiac events in the UK database, there was 89 versus 433 in this TriNetX group. So we have a database that we know is dedicated to CF, which has a lower rate than those with TriNetX, which is more of just a generic database. But that's where they took these numbers to actually calculate the propensity scores for hazard ratio. So that's where this 433 comes in. That comes from TriNetX. That doesn't come from the CF patient registry or from the UK database. And they did see increased risks of major adverse cardiac events, MIs, no difference in heart failure compared to age and gender matched controls. They also looked at people with diagnoses of lupus, rheumatoid arthritis, and HIV, and no difference. So they're saying basically with this that patients who have chronic diseases have the same risk as people with CF. So other diseases that we know that we should be paying attention to. I'm going to skip this last case series. So what I would say is really my considerations as we run out of time. So who should we be screening for hypertension within the CF population? Because I told you we have a young age group that has a high risk of mass hypertension. So really, the USPSTF recommends we screen everybody over the age of 18, but should we be screening more of our patients because they have this risk of mass hypertension? Really, we should be using this ambulatory blood pressure monitoring. If we get a diagnosis of hypertension, should we go on to look for OSA? Since all of them have chronic sinus disease, a lot of them have enlarged tonsils. So certainly something that we should think about before we jump to medication therapy. I talked about we only screen 35% of our population in any given year. So we really need to be doing a better job of screening our people, our patients. But with CF-related diabetes, we have this emerging role of GLP-1 agonists. And how's that going to affect? Because that leads to weight loss for a lot of our patients, better diabetes control. How is that going to play a role in the weight gain we see and those risks that go along with that? The CF Foundation recommends yearly lipid screening, which is different from the US population because for young people, they really only screen every 5 years. So we need to be adherent to this. And then if we diagnose people with abnormal lipids, what do we do about it? Do we start them on statins? The statins interact with CFTR modulators, or should we be thinking about other things like fibrates since they have a lot of triglyceridemia? Along that same line, what is the most appropriate treatment for blood pressures? And since the first line is diuretics or calcium channel blockers, if our patients have bad advanced lung disease, the calcium channel blockers may worsen hypoxemia in those folks. So certainly things that we need to be thinking about for the future. And then I'm going to talk about just reference coronary calcium scanning. This is a useful tool for people who have low to moderate risk coronary disease. Many of our patients get CT chests anyways, and this could be calculated on any CT. So should we just be asking for this on all of our CTs so that we can use that for our risk calculations for the future? So I'm going to leave us with this last figure from Sanduc et al., which really looks at traditional versus our current risk factors for CF, and we're starting to see a lot of those things overlap.